Exactly. Yeah, for me. Yeah. Exactly, yeah.
The one thing that
Reza, hey,
Hey, what's up, man?
God Khalil, Dutch, everyone's here. Love you, dude.
It's good, man. I'm gonna turn off my microphone so I don't make any noise.
Thank you.
yeah, I
Did you buy your ticket?
yeah, so just gonna ask you.
So they're here. Yes. You anybody? Yeah.
Good seeing you.
How you been? Teaching me for you.
I know.
Oh, there you go. So
That's
how you should relax.
already pretty sick.
Yeah.
So I think yes.
Actually, it looks like this there. But it's
as the not sure. Some stuff.
Yeah.
She can make it really fun.
Yes. Now we can start. Yeah. What did we start with? Yeah.
Okay, so there's a Zoom. People are already on Zoom. Oh, hi, Dr. Janik.
All right. Well, thank you everyone for coming to Amin's defense. This is our back-to-back thesis defense day. Good job, AK, yesterday, and good job in advance, Amin. Again, Amin, this is of course, you're part of an amazing cohort of students, all came in the same year, stressing me out every day, worried about whether you guys will all finish. But you're well on track, and you're going to be presenting some of the amazing stuff that you have been able to do. Of course, and I think these photos are all of you, not of your brother, but I could have gotten some of them mistaken. Obviously, you've done a lot of work that you're going to be presenting, but you also did an incredible job mentoring as well, other students, including Yanyel, who I saw was also on the Zoom here. Really appreciate all the effort and work that you put into what you're going to be presenting. Let me advance one slide here. Amin comes to us from UC Irvine with a bachelor's in biomedical engineering. He's a very snazzy dresser. Every time he's presented at a national meeting, they assume that he's already a professor. And it's pretty amazing. And not surprisingly, he's got a ton of academic research experience even before coming to us in the MD PhD program at UCSF and Irvine. Quite a bit of work, and then also in industry at Neuralink. You should ask him about his experience working with non-human primates. It's pretty crazy stuff over there. Big transition to what you're going to be presenting today, but maybe a lot of the same technical foundation and a lot of the same intellect that was required to do all those things. So Really excited to see what he'll be presenting. Every time I came in the lab, these two guys were always together, so it'll be interesting to see how how things stay the same or change as you go into the last 2 years of medical school. But I heard you were both there late Sunday night preparing. So,
And we're both starting on surgery immediately.
oh, that sounds like fun. All right, so good luck. Yeah.
Okay. Thank you so much, Dr. Hsiao. I appreciate your warm introduction. Let me switch to my presentation. On Zoom, can you guys see my screen? It shows that it's sharing, but a thumbs up. Okay, great. Well, hello, everyone. Thank you all for being here. My name is Amin Mahmoodi. For those of you who may not know me, I think everyone here knows who I am, but on Zoom, maybe there are some people who might not. And I'm going to be defending my PhD, where we use deep learning to improve cardiac imaging, specifically improving the quality of cardiac MRI and making it more robust for clinical use. On my PhD committee, we have our chair, Dr. Albert Hsiao, who was just talking. We have my co-chair, Dr. Elliot McVeigh, and my advisors, Dr. Thomas Liu and Dr. Daniela Valdez-Jasso. Thank you all for coming here today. Okay, without further ado, let's get started. In this presentation, we'll briefly cover the role of cardiac imaging and how that is used to diagnose heart disease. We will go over the cardiac MRI, specifically the workhorse of cardiac MRI, cine imaging, and that will motivate my two aims due to the limitations of cine imaging. And we will talk about how we're going to use AI in the form of deep learning to address those limitations. It might not be a surprise to everyone in this crowd and the people on Zoom that heart disease is the leading cause of death in the United States, as well as globally. And in fact, heart disease passes all cancer deaths combined year after year. We have a number of different imaging techniques we can use to investigate heart cardiovascular disease, such as using X-ray to look at the general structure of the heart. We can use CT to look in detail in the coronary vasculature and look at blockages in heart vessels. We can use echo or ultrasound to look at heart function quickly, or we can use nuclear imaging for stress testing the heart. However, the clinical gold standard for looking at the heart structure and function is the cardiac MRI, specifically the breath-held electrocardiogram-gated cine steady-state free precession. In this technique, a patient lies on the MRI table and they're hooked up to electrocardiogram leads, as shown here. The patient is instructed to hold their breath for 10 seconds or more, during which the electrocardiographic R waves are used to trigger the MRI for acquisition of imaging time to the patient's heart rate. This is what that looks like when it's timed well with ECG-Gating and the patient is holding their breath well. On the right, I've included a graphic that's showing in red the short axis view through which the MRI is visualizing the heart. That same red square is the heart shown on the MRI. This can get corrupted if the patient is having arrhythmia, which is an irregularity of their heart rhythm, or if the ECG leads are misplaced or incorrectly triggering. Here's what that looks like. You can see there's blurring in that red square over there. Similarly, if the patient is unable to hold their breath, you can get blurring both in the red square, which is the heart, as well as the abdominal cavity where there is motion in those organs. Also, if the patient cannot hold their breath, then they're no longer a candidate for cine cardiac MRI. Herein, I'm going to be addressing these two problems with the two aims of my dissertation. Problem one, how do we improve the quality of cine cardiac MRI? We will improve the quality of cine cardiac MRI by improving ECG gating with deep learning. How we arrive at that conclusion is by first asking, are ECG-related image artifacts common? And if so, how often are they due to the arrhythmia versus the ECG gating error itself? Can we make cine ECG gating more robust to have less error? And if we make it more robust, can we apply it to historical images that were already acquired to decrease the imaging artifact from those images? Part A, quantifying the prevalence of ECG gating error and arrhythmia in cardiac MRI. Here, I've shown on the left a cardiac MRI of a 4-chamber heart of a patient who's having atrial fibrillation arrhythmia. You can see that there is some blurring going on in the left ventricle. To a trained eye, this is very apparent, and there's blurring going on all throughout the cardiac anatomy. On the right, you can see the ECG tracing for this patient. Oh, if it's difficult to visualize, I can change the light. Sorry, I've never seen. Maybe some of the images, especially the radiology images, might be more difficult to see. Is this better? Thumbs up and dollars. Okay, great. On the right, we have the ECG tracing for that patient. And in this ECG tracing, the R waves are annotated in green dashed lines by a radiologist in training, and the scanner triggers are shown in blue diamonds. We can see that there is an irregular interval change between the R waves, which is a hallmark of this patient's atrial fibrillation arrhythmia that's causing that motion and that blurring. That looks almost indistinguishable in the type of error it causes, the blurring that occurs, if instead the patient had a more regular heart rhythm, but the blue scanner dots are missing or the R waves are not being detected by the scanner. So in order to differentiate between these two sources of error, we grabbed the ECG tracings with the human annotations, and we measured the interval before and after each R wave. That allowed us to algorithmically identify the source of arrhythmia error or irregularities in the R interval. Specifically, we saw that there was a high burden of PVCs or premature ventricular contractions in 5% of patients. There was a high burden of PACs, premature atrial contractions, in 2.5% of patients. And by looking at the overall variability in the heart rates, anyone above 5% we visually inspected to realize that 6.7% of patients had full-blown atrial fibrillation. Moreover, we use that same ECG tracing to look at if the scanner gating correctly found the R wave. Here, the green squares show correct R wave and scanner within 40 milliseconds of each other. The red, there was no scanner gating on this R wave. Using that, we were able to calculate the prevalence of ECG gating error at 1.5 Tesla MRI in 74 patients. And this chart here shows the severity of error. How many R waves were incorrectly missed? Less than 5%, we said that's acceptable, but anything between 5 to even more than 25% of R waves being misdetected was observed in 8.1% of patients. This problem got worse in both prevalence and magnitude when we are looking at higher strength MRI at 3 Tesla. We see that 15.2% of patients are experiencing error, and the error is often at higher magnitude in the ECG itself. This can be attributed to magnetohydrodynamic effects, which are Lorentz forces that affect the moving ions in the blood due to the stronger magnet, and that in turn causes a magnetic field that is picked up by the ECG that attenuates the R waves and accentuates the T waves, here shown. And that gets worse at increasing field strength. Moreover, the higher radio frequency pulses we use at 3 Tesla MRI introduce high frequency noise spikes also seen in the ECG. So then we asked, can we address this problem and make ECG gating more robust using AI in the form of deep learning? Specifically, we developed an AI network that uses 2 seconds of ECG as context, here shown in black square, and in its leading 64 milliseconds, it detects whether an R wave is present. The yellow here is signal that it hasn't seen yet and it's forthcoming. This network was developed using a convolutional neural network architecture with a loss function that we bespoke design that uses a binary cross entropy and a conditional mean squared error loss function, such that in every 2 seconds of ECG tracing that it receives, it detects the R wave and it accurately localizes the specific position of the R peak itself. Similarly, we asked, can we just design a network that can predict upcoming R waves instead of detect R waves in the current window? And we designed a network called the R wave predictor that can detect up to 2 upcoming peaks in future signal by narrowing a confidence interval shown in yellow here around where it thinks the R wave is going to occur. We developed this by updating our last 2 layers of our original network and using a quantile loss function where we're predicting 5th, 50th, and 95th percentile probability of where it thinks a peak is going to occur. And if that probability window decreases to less than 120 milliseconds, which is the typical size at which we would say a QRS complex gets too wide, then we said, okay, pick the middle of that as an R wave. Let's see how those networks perform when compared to both the vector cardiogram, which is the standard ECG gating algorithm that's currently running on the scanner. Those were the blue diamonds that I showed in the previous images, as well as the Hamilton algorithm, which is this state-of-the-art signal processing algorithm that is specifically designed to detect R waves in noisy and arrhythmic ECGs. We can see that the Hamilton algorithm performs well at 1.5 Tesla, but it significantly decreases in performance once you introduce magnetohydrodynamic effects and more electromagnetic interference at higher field. The vector cardiogram is better suited for higher field. However, it still doesn't perform as well as our R wave predictor, which is predicting upcoming R waves 4 seconds into the future, and definitely does not perform as well as our R wave detector, which is robust at both 1.5 and 3 Tesla. Yes.
The Hamilton both predicting and retrospective, or just retrospective?
All of these algorithms are retrospective. The only one that's predicting is the R wave predictor. And we're actually comparing the detections to the predictions. So there is a layup for other algorithms when compared to the R wave predictor. But yeah, the Hamilton is using bandpass filtering, first derivative thresholding, some hard-coded algorithmic design, such as like R waves can't be this far apart. They need to be within this QRX complex. Okay, so now that we have an algorithm that works well, our R wave detector, can we use that to then correct images that are already acquired but have ECG gating or artifacts? In order to do that, we first have to understand how are ECG-gated cine images acquired in the first place. I mentioned that the ECG is used to trigger the MRI. Let's look at it more in detail. Specifically, the R waves or the ECG trigger a segmented acquisition of the spatial frequency map of each cardiac phase shown here. Subsequent R waves then fill that spatial frequency map at each cardiac phase until the entire spatial frequency map is complete. We can then convert that spatial frequency map to the MRI image using the inverse Fourier equation. Here I'm showing it in 2 dimensions. Well, if we have an image that has ECG gating artifact, as shown here, we can reverse this process and obtain the spatial frequency map. Here I'm showing the forward Fourier equation. And if we have the ECG tracing with the incorrect R waves, and we know how many phase encodes constitute a segment of each spatial frequency map, then we can retrace and position those spatial frequency maps to the point in the ECG or the point in time at which they were acquired. Once we do that, then we can get rid of the triggers that were incorrect and correctly reclassify those spatial frequency segments. And once we rebin the spatial frequency maps using now the correct positions in the cardiac cycle where they were acquired, we have a more accurate reality of what the patient's heart rhythm is. However, in doing so, you can see that we end up with empty spaces in the spatial frequency maps. We filled those by an algorithm we developed that takes advantage of temporal adjacency between cardiac phases by filling each K-space or spatial frequency position using a exponentially decaying weighted sum of the phases around it. Now that we have a fully complete spatial frequency map, we can then convert those back into the MRI images. Here's what that looks like for that exact patient that I was showing in that example. This is their actual ECG tracing. The blue dots here are the scanner gating, and the red dots are the CNN R wave detector. We can see the end systolic phase when the heart is most contracted on top, and the end diastolic phase when the heart is most dilated on the bottom. If you reconstruct using the methodology I just described, we can decrease the artifacts and uncover some of the anatomy. This can be seen better in this second example, where you can see the heart vessels and the heart chambers are entirely blurred together. Once we reconstruct, we can recover that anatomy that was previously undiagnosable. Here's another slice from that same patient. Again, you can see the left ventricular outflow tract and the left atria completely blurred together. Now they're not. Now we can clearly see the two different tracks. Even if yes.
You save the raw data, obviously, for these patients.
Great question. So that is a part that we were privileged enough to be able to do because we had the raw data. I showed a very oversimplified mechanism for how you would perform this, but in reality, the images are required at homodyne reconstruction using multiple coils, multiple slices. So the equation I use is a far oversimplification. It's actually a 5-dimensional problem using colloid combinations and using the actual raw scanner R waves that were required, because we can't just fill the missing segments of spatial frequency maps using conjugate symmetry, because it was already acquired assuming such. So it was already only half of the spatial frequency maps that were required.
And the raw data just lives on the scanner and can be pulled off sort of daily or something like that?
We had to work with our wonderful industry partners who were able to allow archiving of the scanner raw data so that then we could use it, including also the raw physiology data. So the ECG, the ECG triggers, if we wanted the pulse gating triggers. Yeah, but great question. Yeah, yes. Okay. So here's another case where the ECG mistriggering is not as egregious as the ones I was showing before. The scanner just missed a single R wave. Even in that scenario, we can see blurring artifacts in the green. We can see an entirely missing tricuspid aortic valve in the yellow arrow. And we can see an entirely missing atrial septal wall in the pink arrow that all are now recovered once we reconstruct. So this is diagnostically important. Moreover, even if the scanner poorly localizes the R wave, here the R wave is detected a little bit off center of the actual R wave. We can see again blurring artifact in the right ventricular free wall, and we can see decreased missing anatomy at the left ventricular myocardium, shown in orange arrow. Okay, conclusion. We saw that ECG gating error is a major limiting factor of cine cardiac MRI image quality, and this problem worsens with increasing magnetic field strength. Deep learning algorithms can more reliably detect R waves from these ECG traces obtained during MRI, thereby optimizing gated cine sequences and may enable a higher quality cardiac MRI image. These techniques can further be used to retrospectively reconstruct cine images and decrease artifacts in existing images that were acquired in the cine mechanism. In our future directions, we've teamed up with our industry partners to plan to integrate this technology onto the scanner to improve the quality of cardiac imaging prospectively as well. Okay, we solved to some extent the first problem. What about for patients who cannot hold their breath and are not a candidate for cine imaging in the first place? Can we use an alternative sequence that is equally valid for evaluating cardiac function and cardiac volume? In this aim, we're going to be automating what's called the real-time MRI analysis for clinical workflow for measuring volumetry and function. Specifically, we're going to go over what is this real-time alternative sequence and what are the components that are necessary for clinical workflow that it's missing. Can we automate those components? And how does our automated measurement using real-time volumetry and function compare to cine measurements that are currently standard of care? Okay, let's go over real-time as an alternative to cine and its limitations for clinical use. As we mentioned, real-time is an alternative in that it's free breathing. The patient doesn't have to hold their breath, and it doesn't require ECG gating because the entire spatial frequency map is acquired at once and the image is reconstructed. There's no segmented acquisition. This may be able to visualize heart structures, looking at heart size, chamber volume, looking at heart muscle, And it can be able to measure how hard the heart is squeezing the blood out, a metric called ejection fraction, which is important in diagnosing, prognosticating, and making treatment decisions for heart failure patients. However, it is not able to be used with currently available AI techniques that are employed in cine imaging. But why is that? Because we didn't acquire the ECG, we don't have information of the cardiac phases. Specifically, we don't know when the heart is the most dilated, called end-diastole, shown in the purple, or when the heart is most contracted, called end-systole, shown in yellow. We need to identify these phases of the cardiac cycle across all of the slices of the real-time acquisition, because doing so, we will create volumes at those phases so that we can measure the heart at its most dilated and its most contracted volumes and how much it's able to squeeze between the two, or the ejection fraction measure that I mentioned. So let's do that. Let's develop AI techniques that are going to automate this currently resource-intensive and laborious process and see how they perform. First, we developed a network that can automatically detect ventricular slice position. In this network, we used an Inception V3 architecture, and this architecture, specifically the Inception module shown here, uses pointwise convolutions to reduce dimensionality of the data, followed by spatial convolutions across all of the channels so that it can learn macrostructural differences between the different channels. That's specifically useful for us because in the channels, we're feeding different slices of the cardiac MRI, and we're going to receive as an output the probability that each slice is pre-basal, too high up in the heart, ventricular, exactly the part of the heart we're looking for, or post-apical, too far low below the heart. When evaluating this network, threshold it such that across a slice, if 30% or more of the frames are detected as ventricular, then let's call that a ventricular slice. Why might that be? Because as the patients are breathing, the heart is moving up and down. So the ventricle might show up in a short axis slice and then go back away. If that's happening more than 30% of the time, we want to be able to measure those volumes across that slice. So that's why we use the 30% threshold. And we can see excellent performance in identifying pre-basal, ventricular, and post-apical slices. However, this can be modulated. We have a general great performance with area under the curve of 0.96. We can use different thresholds to get bias the ventricle more or less, depending on our acquisition. Okay, now that yes.
So ventricular slice detection, just so I get this right, that means you're in the center of you got three regions right now: apical, central, and basal.
Yes. So we have,
This ROC curve is for detecting the central part.
for the ventricular slices, exactly. And the overall confusion matrix is for detecting the central part, the top part, and the bottom part. So the network outputs a probability estimate for each of those segments. I'm just showing yes.
Not gonna, when I was looking at this, you don't go into actually tracking slices. It's just like, I'm gonna put them in one of these three buckets.
Yes. And we'll go over why we don't track the full slices in a second. So actually that's a great transition. So why don't we track the full slices? Because we're specifically isolating the end diastolic and end systolic phases at each slice to create end diastolic and end systolic volumes. So if we grab those frames from that slice, those 30% frames, for example, that's all we needed from that slice for the purposes of volumetry and measuring function. Okay, well, now that we're on this topic, how does this network work? Well, in order to use a network to identify end diastolic and end systolic frames, we needed annotations of end diastolic and systolic frames. I just mentioned we didn't have ECGs for real time, so someone had to sit there and annotate. That's a very time-consuming and laborious task. We did that for 55 patients and saved those for evaluation tests. For the rest of the patients, we employed the cine images that already had the end diastolic and end systolic label, courtesy of their ECG-Gating, but we made them look like real-time images in a synthetic training strategy. Specifically, We low pass filtered and zero padded in the spatial frequency space to decrease the spatial resolution of those images, as when we calculated, our real-time data had lower spatial resolution than our cine data. We then grabbed the label of end-diastolic frame, for example, which was hot-coded either yes or no, and turned it into a probability estimate, and temporally interpolated frames between each frame and distributed that probability estimate to those frames. This allowed us to use a localization regression task instead of a binary classification task. So our network that's using a gradient descent algorithm can better learn where exactly end diastole is and nudge itself toward the correct answer, or learn where exactly end systole is and nudge itself toward the correct answer.
What is the temporal width of that?
Yeah, so there is 37 milliseconds is a temporal resolution of the cine images, between 37 to 40 milliseconds. And when we interpolate 10 frames in between each, they're about 3.7 milliseconds apart each of the. So we don't actually measure the temporal resolution. We use the temporal step as a proxy for temporal resolution.
What's the total temporal resolution of your real time?
They're between 100 to 200 milliseconds. So they initially, when we were collecting real-time data, we had some that had up to 600 millisecond temporal resolution. Those were horrendous. You know, every frame was end diastole, every frame was insys, right? With increasing technology, I have slides if you want, we can go over them. But with improvements in technology, we're able to use parallel imaging. We're able to increase the speed of the acquisition of real time, and our protocol has gone better so that now they're about 100 to 200. Their average 140 milliseconds is the temporal resolution we're using at UCSC.
Okay, sorry to keep asking questions. And in synthesizing the real time from your cines, the flip angle physics and all of that kind of stuff gave.
Yeah, so in our real times, the Philip angle is just slightly larger than the cines. But yeah, that because we're using it in image space, those didn't affect. Yeah. Yes.
How do you determine, or what kind of characteristics do you assign for, say, to distinguish between insystole and endosystole?
In this implementation, how we labeled end diastole and systole is how a human would label it. So you would go through each frame and see the diameter size increase. Then if the diameter stays the same, then you look at the myocardial contraction to see if it's starting to contract or not. And then you pick the one where it didn't start contracting yet as end diastole, for example. So the endocardial volume is the primary. And then if you have multiple frames where the endocardial volume, it looks exactly the same, which often happens, then you use the myocardial thickness to try to eyeball. Is it starting contraction or is it not? It's a very difficult task, actually, as Mariam, who's on Zoom right now, can attest, who annotated a lot of our images. And also, so is labeling the slices. That's also an exceptionally difficult task, because where do you exactly cut off the top of the heart? You can have short axis planes that are oblique, that are partially cutting into the ventricle. Okay, do you include those? Where do you connect those to make a circle for volume measurements? So these all become nuances that can be different from institution to institution, and also can be different from technique to technique. But yeah, that's a great question. Great question. Okay, so now that we had these synthetic real-time data, we used it to train an extreme version of the same slice classification network. Instead of inception v3, this is called exception, because it's separating those point-wise convolutions from the spatial convolutions so that it can more specifically learn microstructural changes within images as opposed to macrostructural changes. So it's more focusing on images that look similar and trying to distinguish slight changes. And we used the mean absolute error loss instead of a categorical cross entropy because we were using a regression task. So we were able to regress to the correct answer. This network outputs the probability estimate of how likely each frame is to be end diastole or end systole. And we're able to first derivative threshold across these estimates to get the true end diastole or the true end systole. Okay, now let's look at these. When we look at the end diastolic network detections and compare it to our radiologists in training annotations, we see that 82.2% of the time is on the exact same frame in those 55 patients that I mentioned. And those 55 patients have anywhere between 5 to 12 slices per acquisition. Each slice has anywhere between 20 to 100 or sometimes 200 frames. So there's a lot of data there. But more importantly, about 97.4% of the network detections were within one frame of what the human annotated, which is from human to human even, that's really good. Similarly, for end-systolic detections, we saw that about 80% of the frames were the exact same frame as the human annotations, and 97.3% were within one frame. Moreover, for some of the patients, we also had ECG tracings. This was very difficult to obtain ECG tracings for these patients and actually co-register them correctly in time so that the ECG is with the start of the acquisition. But for some patients, we were able to do that correctly. And when we overlay that ECG tracing on the network detections, we can see where exactly the end diastolic and end systolic predictions are. We can normalize the ECG across the entire acquisition. Here, the black is the median ECG voltage, and the tiny gray is the 5th to 95th percentile for ECG for that patient. And we can overlay a probability density of those end diastolic and end systolic predictions to reassure ourselves that not only is the network performing similar to a human annotator, but also physiologically, it's in the correct position where it's detecting end diastole, which should be right before the R wave as the myocardial contraction starts. The R wave signals the contraction of the ventricle. And the end systole is right after the T wave. That can be variable from patient to patient. Yes.
When you're doing this, you broke it up. So when you do real time, you watch for a while, then you move the slice, right? And you watch for all, you move the slice.
Mhm.
So all of this analysis here is just when I push my slice to a certain place, I watch, and then you do this analysis to get your end diastole and systole and stuff like that. Okay. And in that slice, the heart is beating and it's coming in and it's coming in.
Yes. Free breathing.
You never stack the whole thing together, like look at all of those slices together, or you do it sort of one position at a time.
I'm not sure I understand exactly what you're asking.
8 slices,
Uh-huh.
8 short axis slices that I've started at the apex, I've moved up to the base. So I watch each one and try and figure out what's going on.
Mhm.
This analysis is done in each one of those.
Yes, that's correct.
It doesn't include the other 7
Okay,
slices.
so if you were to stack the slices on top of each other, the end diastoles and end systoles line up in completely different positions with respect to each other. So that's why we wanted to have a per slice specific detection. So then we can, for example, if end diastole is here in this slice, here in this slice, we can then measure end diastole intervals to get a similar type of heartbeat between slices and then overlap those to form the volume. Does that help?
Yeah.
Okay. Okay, so final step in this pipeline. Now that we have our actual end diastolic and end systolic volumes that we created, we actually need a way to measure those volumes. So we used a segmentation network to segment the myocardium and use the endocardial border to measure those volumes. This network is a unit architecture employing a dice loss function that we are using in the lab for multiple projects. And it inputs cine images that have been augmented every which way you can imagine. And it detects a myocardial mask for those images. It also resamples the images to 1 millimeter, so then we can just easily stack those on top and calculate volumes. Okay, instead of component testing this specific network too, let's just put those volumes together end to end and see if our automated real-time volume measurements that have been created by this mechanism of cardiac slice identification, phase identification, and volume segmentation measure up to cine measurements done by a cardiothoracic radiologist, Dr. Hsiao, for those same 55 patients using clinical grade software. It does. So here's the end diastolic volume. On the y-axis is the real-time measured automated volumes. And on the x-axis are the cine measured volumes by Dr. Hsiao. we see an excellent correlation between those, and we see just 3 milliliter bias in those measurements. Similarly, for end systolic volumes, we see an excellent correlation of 0.95 with no bias between those measurements. And more importantly, when we're measuring ejection fraction, which is the function of the heart, we see great correlation of 0.84 with no bias between those measurements.
Line,
This line? So this is the correlation line. It's 0.84.
it's correlated, but the real time is smaller than the.
Yes. So there is variability between the real time and the cines, because the cines, I'll go over this right now. The cines are actually a single point measurement for each patient for the end diastolic and systolic volume. So you have one and one,
Holding their breath,
and they're holding their breath.
breath at end expiration or end inspiration.
They hold their breath at end inspiration. Expiration? Oh, okay, expiration.
Do you think that has an effect on it?
Well, if you depress your diaphragm, you're increasing heart size, right? Because you're not pushing into the heart. I would assume maybe slightly have a larger ability to fill the heart, potentially. Yeah. It's just conjecture.
I mean, there's a.
Yes.
See.
That's true. And it's a great thing you mentioned, because now we have the ability to investigate these questions. And specifically, we have the ability to investigate. Each patient has a variability in their physiologic measures of ejection fraction. So it's not just this one number. In that one scan, this patient had multiple ejection fractions. The heart went through a bunch of different contraction patterns. So yes, absolutely. What does it due to? Is it due to the breathing? Is it due to the physiology? Is it due to arrhythmia? Is it due to so now, because we have the ability to measure these in real time, we have the ability to investigate questions that we couldn't potentially investigate before. Yes.
Sorry, I don't know if I've ever asked you this before.
Save it up for.
But if you take a big deep breath in, what happens to the blood in your chest? Is there more blood or less?
If you take a deep breath in, you fill your alveoli. I assume that increases some pressure on the microvasculature. So there's
when you take a big deep breath in, you actually create negative pressure in your chest, right? So
yeah, that's why I initially was.
So you increase volume loading. So you can
Okay.
imagine that your cardiac function or ejection fraction may increase.
Yeah, I agree. I think that was my reasoning for when I said if you depress the diaphragm, the heart increases in size, is because the negative pressure that's pulling the heart. Sorry, but yeah, I thought you meant like does the total volume of blood we have available change? Yes.
I think you may have touched on this before, but what's sort of the effective temporal resolution between cities and real time? So that's that you think that.
Well, the effective temporal resolution for the cine is the time required to acquire one spatial frequency segment. So that's the repetition time times the number of phasing codes, which for us, the repetition time is between 3.5 to 4 milliseconds. The phasing codes are anywhere between 10 to 12. So we're getting like 40, 45 millisecond effective temporal resolution. But for cine, or for real time, then the temporal resolution is the time to fill however much of the K space we're filling before homodyne reconstruction for each coil. That's typically, I don't know, I haven't looked at how many exact phasing codes are acquired during your real-time acquisition, but we've measured it as the space between one image to the other, and that's where we're getting the 140 millisecond.
So what you're getting at could just be blurring on end systole or something, or you might be missing the exact timing. It's just.
Of course, I did that analysis looking at the temporal resolution correlate to end diastolic. I didn't include it in this presentation. I can pull it up if we're interested. There is absolutely no correlation to the temporal resolution in end diastolic volume and systolic volume. With ejection fraction, there's a row of 0.15, which is very weak correlation. Exact.
So there was a slight underestimation.
Yes. So that is due to potentially temporal resolution.
So can you go back to the graph? See, that's a finding. Right? You know, because then you don't want to say, oh, this is just, you know, a line.
And that's a very valid comment because in fact, a lot of these patients have certain pathologies that warranted real-time imaging, right? So for example, we couldn't image them with CNA for one reason or another, right? So it could be a finding due to the CNA was poor quality. We tried to limit for that. We tried to get rid of all CNAs with EKG-gating error, breathing error, etc. It could be physiologic finding. I absolutely agree. That's exciting. It's an exciting avenue to investigate, which we could potentially do before publishing this aim. This aim still hasn't been published.
Ask about that. You have to ask.
Oh, we'll get behind it before the reviewer.
Yeah, no, so Dean, I think it's a good point. When you look at your results, it's always good to not get too colored with your desired answer, right? And the desired answer is that there's a perfect correlation, 1-to-1, perfectly on the diagonal. And but when you look at these results, would you say it's a perfect correlation, 1-to-1, perfectly on the diagonal?
Definitely not.
Maybe not. So then there needs to be some answer for that. Whether you know the answer or not, that's okay. It's important.
Also, did you try the fit without those two outliers? Because then it would be more.
No, I haven't looked at
None of the black dots go over the dashed line.
Yeah, but
Right.
it's that's like a.
Oh, that's slow.
yeah, you're saying these two. Yeah.
So
Yeah.
But there's,
Yeah.
it's very interesting. I don't know.
Yes. And I think I looked at these two specifications. These are structural heart disease patients. They're transposition of the great arteries. So they're
These patients?
yes, the two. So I can try to exclude those potentially.
If there's
Yeah.
they're killing outliers and there's a reason for it, that would change your slope.
That's fair.
I think it also can be, they're breathing on one axis and they're holding their breath on the other. Maybe that's it.
Fair. Yeah. This it's like different baseline scenarios.
Like Valsalva, see what happens.
Hey, we can get that measurement. Okay. So again, now that we have these overall variation measurements instead of a single measure, I think
His name. So
those are courtesy of formerly Artis, now Tempest Pixel, which we use to de-identify and view the images. So these are the de-identified phonetic IDs.
so you can pronounce them all?
Some you don't want to pronounce.
Yeah, some of them are very close to words I usually use in my lexicon that I shouldn't, but I try not to pronounce these. Okay, so in conclusion, real-time MRI may be employed as an alternative to CNA in patients with decreased breath hold capacity, but quantifying cardiac volume currently is slow and laborious. We can use deep learning algorithms to automate this process by inferring cardiac slice, cardiac phase, and left ventricular volume from real-time, thereby allowing our functional analysis from real-time MRI to be comparable to CNA. And now we have excellent points of investigation of why maybe it may differ. This technique may enable a more robust clinical cardiac MRI by enabling utilization of real-time clinically. For our future aims, we plan to implement this pipeline as a post-processing software for clinical workflow, hopefully. And potentially, we could use the phase estimation part to time our inversion images so that we can find the quiescent phase in the heart. I'd like to bring us back to the central problem of what motivated this thesis. We address these two aims in our two different aims. One, we address the ECG gating, both prospectively, hopefully soon on the scanner, and retrospectively. and we addressed creating volumes from the real-time images. These are immediately deployable clinically, which is great. And I'm grateful to have the opportunity to work on projects like this. And also, these create new avenues for researchers and clinicians to investigate potentially things they couldn't before. One, we surreptitiously came up on. Another would be arrhythmias, for example. You could use Cine R-wave detection with algorithmic beat classification to do morphology-specific imaging. You could also use real-time imaging to create volumes for patients with arrhythmia using image-based heartbeat classification. These can allow researchers and clinicians to look at the strain and the biomechanics of these pathologies in ways that potentially they couldn't before. With that, I'd like to acknowledge my one and only funding source, Dr. Hsiao. And I'd also like to acknowledge UC San Diego Medical Scientist Training Program, as well as the Bioengineering Department for accepting me and also funding the first year and first 2 years of medical school. Also indirectly and directly like to acknowledge GE Healthcare for their tremendous help and support in licensing our technology for clinical use, as well as for funding our projects in the lab. Thank you all for being here. Specifically, thank you, Dr. Hsiao, for your unending wisdom and tennis analogies. I think you're coming at this candle with a forehand. I'm not sure what's happening. I'd like to thank the incredible members at the IDA Lab and the many celebrations we've had. I think everyone will recognize a theme in these images. I'd like to thank my wonderful parents who have supported me my whole life and have not left a stone unturned. I'd like to thank my grandparents who have always been my #1 fans. Rest in peace, Grandpa. I'd like to thank the matriarchs and the patriarchs in the family who always make sure we're on top of our work and the family gets together all the time. My uncle is here, one of them. And I'd like to thank all the cousins. These are only the ones in the United States. I couldn't include the ones in the home country right now because that would take 16 slides. And specifically, I'd like to thank the cousins who have picked up pickleball as a new hobby. And so we can stop revolving our activities around cake and we can do something active for once. And of course, I'd like to thank the recent group in the lab who have been tremendous, especially helping me with my AM2. Mariam, Evan, thank you guys so much. Everybody else, thank you all for coming. Alta, AK, thank you guys, Herez, and Roshan, of course, with our clinical trial, hopefully it goes well. With that, are there any questions? Yes, Evan.
That was a fantastic talk. I think you had a really good explanation of the underlying MR physics that's where you guys really learned a lot. Did have one question going back to AIM-1. When you're rebinning your case space, if I'm understanding your image correctly, you're actually introducing an additional frame in the heartbeat. I kind of hesitate to call it increasing temporal resolution.
Yeah. So I can pull up the slides again. Some of those images, you completely change the heart rate and the number of frames that could be acquired based on that electrocardiogram. So for example, can people on Zoom see my screen again? Okay, cool. Let me go back to the slices, for example. I think this is the patient you were mentioning. Yes, so this is the patient you were mentioning. If you look, the originally reconstructed heart rate thought the patient had a heart rate of 159 beats per minute, right? There's only so many phases you can fit in between those. So really each heartbeat was cut in two. And so there were that many phases acquired. Unfortunately, a different segment of phase encodes were acquired at each of those. So then you're limited by what was acquired. And absolutely, you uncover phases that were merged together as one. Yes.
Since we're on AIM 1, I'm gonna ask a follow-up to your Senate exam, and I'm hoping you have a slide on this. So can you talk a little, so first of all, great talk, really nice work. So just had some specific questions. One is for the algorithm that's detecting, the cardiac activity. Can you talk a little bit about what are the features and how detecting those features allow you to outperform sort of state of the art?
Yeah, so that's a great question. I think when we were first discussing it, you were interested in, is there like a heat map or something we can use to see what the algorithm is exactly looking for? I unfortunately don't have an exact answer for that, but I can walk you through the architecture of this network. So here we have these convolutional blocks that are acting in a way as signal processing algorithms in themselves. Their CNNs have been traditionally shown to be very robust to noise in identifying signal. So in this case, we have noise introduced and it's able to regress to this specific R wave by convoluting out that noise. And in this specific architecture, what makes it useful is there is no up convolution from there, like there would be in a unit architecture that we use for segmentation. This one is, although it's a big network, is one of the first ones. We just use it off the shelf and we updated the last layers. But because we're only feeding in one-dimensional data of voltages, it actually performs very quickly. Their execution times less than 4 milliseconds per 2-second context window of detect, and it's detecting R waves, which is way faster than what's currently on the scanner. That VCG triggering, it's been reported to be up to 20 millisecond delay between when it recognizes the R wave and when it actually triggers.
So what is the temporal? So when you say convolution block n equals 256, is that the number of time points in the?
No. That's so a convolution is looking at the image, right? And it's the
This is looking at time series, right?
yeah, which I guess time series is like a one-dimensional image. Yeah. And it's using data points for example, each 2 seconds it's sampled at 250 hertz. So each 4 milliseconds is a data point. So it's using those data points.
So when you say 256, that's 256 data points.
That would be the current, right?
Yeah. The number.
Oh, that's fair. Okay.
Kernel.
I do not know off the top of my head what the size of the kernel is. I believe what we did in the training data was we advanced each window by 4 milliseconds, but we fed the whole window. So it's possible it was the entire 2 seconds of, but I can look into that.
That's a good question, actually. Maybe you know the answer to this. When you're working with image data, what is the typical size of your kernels?
Good question. I can tell you if that's similar to what we downsampled the images to for, but I don't know the exact size of the kernels.
But they're often 3 or 5, right? So they're taking the clock of JSON.
Oh, sorry. Okay. If this is the image, the kernel you're mentioning is the piece that we're convolving across. Yes, usually they're 3 by 3, and some of the networks is 5 by 1, 5 by 5. Sorry, I was not understanding what we were asking. In the previous networks that I showed for the other technique, they're 1 by 1, then followed by 3 by 3. And those kernels, I guess they filter the data to what they're looking at.
There's so many that you can generate out of a kernel of 3. And when you're in one dimension, then there's only so many variations of up and down, right? 3 by 1 kernel. So you may have to go 5 or go 7.
That's fair. I'm not sure what the exact kernel size was that we used for this network.
And do you think, like, so this was designed on, I guess, the ECG data,
Yes.
like, sort of generalizable, do you think this will be for say, other institutions or other scanners?
Yeah, great question. We actually externally validated this network in ECGs obtained from the MIT arrhythmia database. So these are 41 patients, 47, we used 6 to update the network, but 41 patients who all had severe arrhythmias, and they were acquired outside of the MRI at a different sampling frequency of 1,000 hertz, as opposed to ours, which, or sorry, ours is 1,000 hertz. This was acquired at 360 hertz. So it's a different sampling frequency than ours. And we can see that specifically the purple here is the R-wave detector. The yellow here is the Hamilton algorithm, and the blue is the R-wave predictor that's predicting R-waves. It robustly performed on par with the Hamilton algorithm, which is specifically developed on the MIT BIH arrhythmia data set.
And these ECGs from this data set were standard 12 lead ECGs or whatever?
No, they were actually, the reason we used this data also was they were 2 lead ECGs in this similar
Okay.
reverse J format that our MRI ECGs are placed in.
It wasn't in the scanner.
The patient was not in the scanner. This was ambulatory ECGs in the emergency department and also Holter monitor for patients who were having severe arrhythmias who needed to be monitored.
And my recollection of years ago doing MRI with ECGs, just like, why you're doing this thesis is such a pain in the butt, right? So is that you have like 3 or 6 options or something. And depending on the angle of those options and the hydrodynamic effect of the ECG changes a lot. Did you use all of those for each patient, or did you just pick one and say?
So for our specific data, we use the reverse J configuration, which provides 2 channels of ECG data,
So you have
2 different leads
leads.
essentially. Yes. I have no idea what orientation they put each lead. They could have misplaced it. They
Yeah,
could have put it in the right place. They could have reversed it, and we train on all of that. And we evaluated it on a test set equally of all of that. And also we ensured that while in the training data, we had multiple ECG tracings per patient. The testing data only had 1 ECG tracing per patient so that we don't bias the results to any one pathology, for example. Yeah, great question. So I assume the higher fidelity of the ECG, the better the network performs. Right now we were trying to develop something that works in the clinical environment. So let's use clinical data.
Oh, okay, yeah, lasers open. Okay, like a quick question, and kind of because, as you know, I'm interested in pulmonary hypertension, and most of the work and the images you show were on the left ventricle. Does your algorithm and everything work equally for other patients, in this case, the right ventricle?
So our segmentation algorithm specifically doesn't. That one's segmenting the myocardium in the left ventricle. In fact, the reason why we did separate phase estimation networks and segmentation is so we can use it with other segmentation networks. Now, and diastole is based on the ECG. I believe it would be similar for both left and right ventricle. Maybe one ventricle could start contracting few milliseconds before the other. However, I think the phase estimation should be robust because it just picks end diastole, and so it's not specifically trained to look at anything in the image. However, the humans did look at just the left ventricle. So it's trained presumably if the ECG aligns with images that also had their right ventricle in quiescence or end diastolic or end systolic phases, then yes, it could be used with those, at least for phase estimation. And of course, slice location is also based on the left ventricle. However, the right ventricle and left ventricle are on par depending on the imaging plane. You may miss.
I mean, in patients with pulmonary hypertension, can you imagine whether end systole would be in the same place for the LP and RP? Would one be?
Well, you know, if depends on how severe their pulmonary hypertension is, of course, and if you have right ventricular dilation due to the pressure that's on the right ventricle, you could potentially have a more dominant right ventricle in severe pathologies. And so, and diastole is when the heart is most filled, like maybe the right ventricle is limiting left ventricle from contracting, so you have a longer end diastolic phase potentially. I'm just assuming, and I have no data on any of this. Yeah.
I think Brandon had some data. Sometimes it takes longer for the RV to contract.
Yeah. Which is what I would assume as well.
So for the real time, was that just like Cartesian sampling or what was
Yes, they were segmented Cartesian acquisitions. Sorry, the real time were one shot Cartesian acquisition. I believe we didn't do radial sampling for any of the Cine or the real time, and Cine were also a Cartesian acquisition.
You have the raw data for the real time?
We do. I haven't looked at them yet, but we do have the same scan archive data for the real time. This is there's a lot I didn't go over, specifically involving proprietary data, proprietary software, how these are encoded, how they're saved, what the scan archive look like, etc. We had to work with our collaborators to learn how the Cine data, for example, is encoded in order to be able to use it. I believe there need to be similar discussions on how the real-time data is encoded so that we can use it, because I looked at it and didn't look very similar. Yeah. But when we were discussing during the Senate exam, you brought up an excellent point of why don't we just look at the case-based data and try to detect these phases through that. And I wanted to do that. Well, it was a 6-month process learning how to use the Cine scan archives. And it was.
On your last slide, when you threw it up and you had all of your real-time data there, you highlight the diastole and systole. So I've got like 20% of the boxes are highlighted. Right? There's data out there in all those other boxes that could be used, right? To predict where things are going to happen. So it might be worth somebody figuring out that.
Yeah, I absolutely agree. And you said 20%. These are much longer than what I'm just showing with the black dots that this is only a part of it. Yeah. Absolutely. I agree.
So you guys, like, I mean, it seems like for this stuff, it's a lot of, the low rank or KT sampling type stuff, give you a lot of information.
Yeah, absolutely. And
compared to this approach. And I guess the related question is, if you could have any sequence you wanted, would you be better off with spirals? And you can sort of revisit in case, sort of just is there a better way to do this?
Yeah. I think we were discussing maybe spirals or radial acquisition would be better, especially if we're collecting less and less of the spatial frequency map. That way you're concentrating on the center of K-space where the most of the pertinent information are, and maybe at the cost of the edges, which are the higher frequency, spatial frequency data. However, regarding low rank approximations, for example, and parallel imaging, those are things that I have hidden slides that I was going to mention. We we use, for example, to speed up the real-time acquisition, which are steps taken before we reach our post-processing pipeline. So there should be no reason why they can't be occurring in conjunction or in series.
Like your temporal basis functions that give you information about where you are, right? Like coefficients.
Yeah, absolutely. I would think so.
And diastole and systole, right? For this project that you've got here, basically you only need low rank data.
Yeah.
Right? Because basically,
yeah, you could.
The integral under the image is big, and then when it squeezes down, the integral under the image gets small. That's like DC, right? So basically, you could go pretty darn fast with low rank data, I think, and get high time resolution for that.
Yeah, I would agree. We could really decrease the matrix of data that we're using and go forward from there. Probably, and also the network we're using is specifically designed because, again, it's not doing up convolutions, it's just down convoluting, and it's one of the separation of the pointwise and the space 3x3 kernels actually was a technique Google developed specifically to speed up the processing. So overall, end to end, this could be a really fast phase estimation.
So you can see the difference for the more clinically oriented people are thinking in low ranks, thinking more higher ranks. I'm thinking in this case, it's great that you're looking at sensitivity. You just want to know ejection fraction. Is it a good? Are you improving or you're not? But you have a lot of data, right? And so in a way, can you learn something from the process through the cardiac cycle? And is there something that can give you information? Because a lot of times we tend to simplify time series to just peaks, whereas important about in between the changes.
Yeah, absolutely. And for example, looking at strain would be an excellent implementation here using these real times to look at heartbeats of similar size in terms of temporal size across each slice, and then looking at how the strain both maybe globally as well as regionally occurs throughout the cycle.
I guess a framework be modified to be able to get that.
Yeah, great question. So the current framework we have, we're generating volumes by isolating parts of each slice and stacking them on top of each other. We actually create what we're calling pseudo-CNAs, which are these short, few frame long volumes that you can use as if it was a acquisition itself, and you can perform post-processing on that. So for example, Evan developed a deep learning network for measuring strain on the short axis slice in Cine. We could augment that network to perform measurement of strain in these real-time data.
Would this be something you could do, say, for instance, if you're following a patient and you say, maybe you get one acquisition day one, another acquisition day after? Would that be something that then you could say may compare? Because a lot of times seems that we take things very sort of information, isolated information, and we're really not carrying out that follow-up.
Yeah, I love where your head's at. But when you mentioned the more clinically oriented audience, it's so hard to get patients in the MRI. They have sometimes when they reschedule, there's months before they can come back. The scanner, each MRI is 1 hour long because of all the different series we're doing. And so it would have to be research grade. Are we only limited to that scan? And then where would it be? Even our research scanner at ACTRI, we're seeing actual clinical trial patients. We're seeing actual congenital heart patients. So getting the time to do that has logistical bureaucracy. But putting those aside, yes, you could potentially have a progression or looking at, for example, certain pathologies, how they develop.
So, another perhaps useful thing about your second name is that do you need an EKG, the DDBCG leads placed on the patient?
Well, no, we didn't have these for these. Yeah.
ECG, you don't need like pop drops.
Oh, it speeds up the work. Fair point. All right, you got me with my own logic. All right. Yeah, that's fair. All right. Hopefully. Yes.
I might understand what you're doing with the pseudo-CNAs completely, but how many frames per beat? Do you increase the number of frames per beat? Like you increase it from 150 do you increase the resolution from 150 milliseconds? It's still going to be
No, we just it's like a imagine it's a time series and we just cut sections out, put those together. No,
So how many,
there's no interpolation, no,
how
nothing.
many time points would you say you have for heartbeat?
It really depends on the RR interval of that heartbeat. Sometimes, as is shown here, there's a lot between one end diastole to the next, right? If I can zoom in on here, you see one end diastole in blue here, and then the other one all the way here, right? But some patients are one end diastole here, one here, right? So it really depends. It's specific patient to patient. It's specific to the temporal resolution of that scan. And it's specific to if they had coffee, that, that earlier, is their heart rate faster or slower? Yeah, it's variable. We have some pseudocinates that are 3 frames long. We have some pseudocinates that are 15 frames long. Oh, there's a question in the audience. RP detection to the next level by demonstrating improved image quality. Oh, thank you very much, Dr. Oh, I don't know if you guys can see the comment. This is Dr. Janish, our collaborator from GE and the head of cardiac MRI at GE. I apologize for. Yeah, thank you. Are there additional questions? Questions on Zoom?
All right.
Oh.
So this is where we ask the general audience to grab a coffee and a muffin.
This is when we make you sweat.
Yeah.
Exactly.
All right. The suit comes off. Should I end the Zoom recording?
Yeah.
I think so. I think the committee's all here, right?
Yeah.
Yes.
So you could just add this.
Thank you guys for coming. Thank you, Reza. Thank you, Mariam. Thank you, Daniel. Really appreciate you guys showing up.
We're also